Welcome to my YouTube channel, and today we are going to talk about management of preeclampsia. Kindly make sure you subscribe, it will cost you absolutely nothing. Management of preeclampsia, we're going to begin with prevention. And in terms of prevention, the first thing that you can administer is calcium supplementation. However, it is noted to be effective only in high-risk women, but not effective in low-risk women. The next thing you can administer is aspirin, which is antithrombolytic. And this is baby aspirin, that is low dose aspirin, that is 81 mg per day. Prophylaxis is recommended in women who are at a higher risk of preeclampsia and should be initiated between 12 and 28 weeks of gestation, and optimally before 16 weeks of gestation. And this baby aspirin is to be given daily and to be discontinued until delivery. So you also ensure good prenatal care and regular visit, and through this you are able to identify early diagnosis of patients who do not have such conditions. Kindly note eclampsia, which is when you have preeclampsia in addition to conversion, cannot always be prevented. It may occur sudden without any warning. So in terms of management, we have the principles of management, where the first one is to prevent convulsion. So already I have preeclampsia. The first thing I have to note is to prevent convulsion, because preeclampsia is just before eclampsia. So prevent eclampsia and then regulate the blood pressure, and delivery is the definitive management of preeclampsia, because in preeclampsia, who is the problem? Placenta is the problem. So when you deliver, meaning you have delivered the placenta, you will have cured the problems. So definitive treatment obvious for preeclampsia, as I said before, is delivery. However, the risk of early delivery is balanced against the gestational age and the severity of preeclampsia and response to other treatment. So for example, if the baby is less than 34 weeks, then you are ish on when to deliver or not. If the severity of preeclampsia then is more of severe, then you are prone to deliver earlier compared to preeclampsia without severe features. And then respond to treatment. So if the treatment that you're given is not responsive, then meaning that we will continue having an elevated blood pressure, which will predispose to increased mortality of the mother, then we will lean on the side of going to deliver. So usually immediate delivery after maternal stabilization, e.g. when you have controlled your seizures or when you're beginning to control blood pressure, is indicated in pregnancies that are greater than 37 weeks. When you have eclampsia, kindly note, when you have eclampsia, make sure you deliver this mother within at least 18 hours. And then preeclampsia with severe features. If you have eclampsia with severe features, then you go to delivery if the pregnancy is greater than 34 weeks, or when you have deteriorating renal, pulmonary, cardiac, hepatic function, or when you have non-reassuring fetal status. Kindly make sure that you are in a battle between two things, the mother and the fetus, and you have to be given a decision to choose between the mothers and the fetus. Who you choose? Obviously the mother. So you put the mother's health first, then the fetal's health second. So if then you have something that is interfering or that is deteriorating the mother's health condition, then you have to go and deliver, at least to rescue the life of the mother. So management of mild preeclampsia or preeclampsia without severe features. I think the key word to get here is to give the patient bed rest. Number 2, to ensure that we don't progress to severe preeclampsia. Number 3 is to deliver. So that's just what we're going to talk about here. So bed rest and daily weighing. Daily weighing is helpful in terms of, if you know this patient will be predisposed in extravasation of fluid from intravascular to extravascular, mean this patient will have increased weight gain due to edema. So you daily monitor that weight to see, are we progressing to the severe end or are we really improving? Next is hospitalization, and if you cannot, home regimen antihypertensives, and then daily urine dipstick measurement of proteinuria. So this proteinuria that you already have, is it worsening or is it improving? And then blood pressure monitoring, and then fetal heart rate testing, and then periodic 24-hour urine collection. You do an ultrasound for the baby, liver function test, renal function test, coagulation profile, and then later you deliver. So just to note is to ensure the patient has gone for bed rest, and ensure that you give hypertensives and we don't progress to severe preeclampsia, meaning that we monitor liver function test, renal function test, coagulation. We also monitor the blood pressure and even dipstick, among other factors. Management of severe preeclampsia. So the first thing we're going to do is to prevent convulsion, and with that you're going to give magnesium sulfate. The next thing you're going to do is control maternal BP, and through that you're going to use antihypertensives. And the hypertensives that you're going to use is labetalol, nifedipine, medeldopa, and hydralazine. And then the third thing is delivery. So when do you deliver? You can deliver if the fetus is greater than 34 weeks. So this is the definitive mode of delivery if severe preeclampsia develops, or if there's evidence of fetal lung maturity, that is when the fetus has reached around 34 to 36 weeks, or when there's fetal and especially maternal jeopardy. And then you also observe the signs and dangers of uh, preeclampsia, that is severe headaches, epigastric pain, visual disturbance, among others. So if there's any doubt about the grade of preeclampsia, then the patient should always be placed in a more severe grade. So patients who improve on bed rest should be kept. So if a patient came in with severe preeclampsia and they have improved dramatically, then you don't take that patient from severe preeclampsia to mild. You keep the patient in that grade that they came initially. So patients who improved on bed rest should be kept in the grade of preeclampsia which they were given at the initial evaluation on admission. And then the diagnosis of preeclampsia with severe features is made only one of the symptoms or signs is present irrespective of the blood pressure or the amount of proteinuria. This statement means that severe preeclampsia can be made if there is a severe signs or symptoms, irrespective of the blood pressure or proteinuria. So when preeclampsia arises in early second trimester, that is 14 to 20 weeks, then you'll be like suspecting, what did we define preeclampsia is? Preeclampsia is when you have elevated blood pressure with proteinuria or severe features of preeclampsia when the patient is greater than 20 weeks of gestation. So now it has developed 14 to 20 weeks. Then you suspect that may not be preeclampsia. So what that may be, it may be an hydatidiform mole or choriocarcinoma, which should be considered, which can present as preeclampsia. Delivery, which is our definitive therapy or a definitive treatment. When can you deliver? Let's just recap from what you have said. You said you can deliver, number one, if it's eclampsia, that is number one. Number two, if there are severe features of preeclampsia, which I've talked in detail about. Number three, if this fetus or maternal, the mother or the fetus is being compromised in terms of end organ failure, and there's increased mortality of the mother or the fetus, or when the pregnancy is near term, that is greater than 34 weeks. So preeclampsia close at term or close to term, that is greater than 34 weeks, where the fetus has achieved lung maturity. Then impaired maternal end organ, as we have mentioned before, compromised fetal growth or impaired placental function or non-assuring fetal status, and eclampsia, as we mentioned before. So it is the mode of delivery. Vaginal is preferred unless it's an obstetric indication. Then cesarean can be preferred. And then before, if you deliver a pregnancy that is before 34 weeks, then you have to give corticosteroids for what? For lung maturation. In addition to lung maturation, what does corticosteroid help about? So you can comment in the comment section. Apart from corticosteroids helping the child to achieve lung maturity, what else does it prevent? And there are three key of them. So if you need to get to know those key three of them, I have a video on anticorticosteroids. You can go and visit them. Thank you.